We are live.
Okay, thank you, Sunil. Good evening, everyone. Welcome to the ARC PG training program. So, as you all are aware, since it's the 60th episode today, so from past 60 episodes, we have been running through the first of all, the case presentations, the journal clubs, and the short cases, the charts. So basically, these all are make all our postgraduates ready to face the exams. So that was the main intention to start this, the PG with a different kind of program. I know there are many other postgraduate programs also running parallelly in an effective way, but this was to bring you up the best out of you. And first of all, I would like to welcome all the teachers here and all the teachers who are listening to this program. A very happy Teachers Day on behalf of AIOS ARC. So I keep telling all my fellows that keep following. There's something called as the Chinese bamboo. If you all know the Chinese bamboo, the first 4 years, it doesn't show anything at all. Sometimes it's underneath or underground. And it's only in the fifth year that in 6 weeks, it raises to the height of around 80 feet. So I think the postgraduate life is also like that. For 3 years or 4 years with your fellowships and whatever it is, you have to keep building it. What we learn from this Chinese bamboo story, we learn that yes, the first important thing is the growth, transformation. It takes time. So consistency is the key. The second, the perseverance. The third is the patience. I think if we have these three, I'm sure, my dear postgraduates, you will scale to a better heights. We should not think of becoming famous overnight because it takes time for you all. And I'm sure with the experienced teachers we have today in this program, I would like to welcome Dr. R. Ramakrishna sir, Senior Glaucoma Consultant and Advisor at Arvind Eye Hospital, Tirunelveli. We have Professor Pandav sir, the head of the Advanced Eye Care Center at PGIMR Jipmer. And yes, we have another dynamic teacher with us, Dr. N. Sharmila Madam, the Professor of Ophthalmology, Regional Institute of Ophthalmology, Government Hospital, Chennai. So we have two mentors here with us today, who is Professor Dr. Shushil Oja sir, who is the Professor of Ophthalmology, Government Doon Medical College, Associate Doon Hospital, Dehradun. And then we have Dr. UP Dipankar, Professor and HOD, Nechaji Subhash Chandra Bose Medical College, Jabalpur. And yes, on this Teachers' Day occasion, we have two students here with us, Dr. Gaurav Kumar, a second-year resident from Doon Medical College. And then we have Dr. Shivam Pandey, who is a third-year junior resident from Netaji Subhash Chandra Bose Medical College, Jabalpur. So as you all know the format, Dr. Gaurav, so you'll be presenting in a case in 10 to 15 minutes, and then for 3 to 4 minutes by the mentor, and then 15 minutes we leave it for the discussants by the three examiners we have today, Dr. Rama sir, Dr. Pandav sir, and Dr. Sharmila madam. So once again, on behalf of AIOS ARC, our chairman, and all the members of ARC, I welcome you all on this occasion for the Teachers' Day program. So without wasting much time, Dr. Gaurav Kumar, are you ready? Shall we go with you first? You have to unmute yourself, Dr. Gaurav. Yes.
Hello.
You're ready, Dr.
Yeah.
Gaurav?
Yeah. Good evening. Good evening, everyone.
Okay. Yes.
Just
All the
waiting
best.
for my mentor. He will be in 5 minutes. Will be joining.
No problem. No problem. Discussants are here. Examiners are here, so they'll be able to do that. Please go ahead with your case presentation, Gaurav.
You can start, Dr. Gaurav. I am online. Just I will be turning on video in 2 minutes.
Okay.
Good evening, everyone. Today I will be presenting a case presentation.
Go ahead, Dr. Gaurav.
Yeah.
Can make it in a slideshow mode.
Yeah.
Your slides are seen, Dr. Gaurav. You can please go ahead.
Okay. Good evening, everyone. The 34-year-old male was presented to OPD with complaint of headache of 3 to 4 month duration, which was relieved on taking analgesic. There was a history of rheumatic fever 3 years back with history of metal regurgitation and is on penicillin prophylaxis. There was no history of any other systemic illness and no previous ocular symptoms. Am I audible, sir?
Dr. Gaurav, you are very much audible. Please go
Oh,
ahead. So you
okay.
have 10 minutes time to finish your case presentation, please.
Okay. There was no previous ocular symptoms. On ocular examination, the best corrective visual acuity for the right eye was 6 by 6 and the left eye was 6 by 6. And the IOP on the GAT, it was 12 mm Hg in the right eye and the 14 mm Hg in the left eye. The CCT was 520 micrometer and 516 micrometer in the right eye as well as the left eye. The CCT corrected IOP was 14 and 15 in the left eye. The pupil was NSNR, normally shape and normally reactive in both the eyes. The anterior segment was within normal limit. On gonioscopy, there was all the open angles were open. The posterior segment in the right eye, the CT ratio was 0.5 and in the left eye, it was 0.6. The neuroretinal rim was within normal limits in the right eye as well as the left eye. So we have done the investigation part. On the diurnal variation, the maximum pressure in the right eye was 14 mmHg and the minimum pressure was 12 mmHg as well. In the left eye, it was 14 mmHg in the maximum pressure and the 11 mmHg was the minimum pressure. The BP was 120 by 80 mmHg and it was in within normal limit. The visual field, there was no field effect in both eyes, and we have kept the patient under observation and for follow-up. So the diagnosis was made normal tensile glaucoma. The management part, there was a role of IOP lowering and control of systemic risk factor to improve the perfusion. The calcium channel blockers were also helpful, like nifedipine or nimodipine, and newer experimental therapies like drugs and genes were started. The management of the normal tension glaucoma. At present, the treatment objective are to prevent further visual loss by reduction of the intraocular pressure by 30% or more, achieved by using medical or any surgical regimes. Emphasis on the use of neurooperative drugs that may act independently of the effect of intraocular pressure lowering. The balance between protecting vision and the iatrogenic damage. Now we have the discussion part, the normal tension glaucoma. And this is a form of open angle glaucoma with glaucomatous optic neuropathy, corresponding visual field defects, and IOP consistently lower than 21 mm Hg. The features of NTG. The mean IOP equal to or less than 21 mm Hg on diurnal testing with no single reading greater than 24 mm Hg. Glaucomatous optic disc damage and visual field loss may be fine. Open angle drainage on gonioscopy and progressive optic disc damage. Absence of any secondary cause of glaucoma. Optic disc features more common in NTG. So the disproportionately large amount of cupping compared to the amount of visual field loss, more sloped, less steep neural rim edge with shallow cup, preference for neural rim loss temporally and inferiorly, larger than average optic disc, greater frequency and extent of peripapillary atrophy and loss, higher incidence of optic disc hemorrhage, and greater chances of localized defect in NFL. The signs. The following features may be more frequently seen in NTG as compared to the primary open angle glaucoma. The first one is the disc hemorrhage. The second is the deep focal notching of the rim and the peripapillary atrophy. The risk factor for progression of NTG, IOP near the upper limit of normal, deep localized notch on the optic disc rim, an optic disc hemorrhage, low systemic pressure, far advanced cupping and field loss, younger age group, and evidence of peripheral vasospasm. The epidemiology, NTG is a disease of elderly, more commonly in females. Positive family history in 5 to 40%, and the POG prevalence in Asian population is between 1% and 3.9%, with a proportion of NTG somewhere between 46.9% and 92.3%. The pathogenesis part, the factors involving etiology of glaucomatous optic neuropathy. The first is the pressure dependent, it is related to IOP, and the pressure independent, that is abnormal blood flow, systemic hypertension, abnormal blood coagulability. The pathogenesis part, as we can see the in the normotensive glaucoma and the hypertensive glaucoma, the vascular dysregulation. So in NTG there is lowering of BOP, this BP and the lower side of the IOP. It causes disturbed autoregulation, which further causes unstable ocular perfusion, which may lead to reperfusion damage, that's causing tissue remodeling, or there is activation of astrocytes, which may cause this apoptosis. Whereas in the STG, the IOP is raised. So the same thing is happening, the unstable ocular perfusion and the reperfusion damage and the tissue remodeling. And on the other side, activation of astrocytes, that is causing the apoptosis. The systemic hypertension in NTG. So this is the HHS public access. So the conclusion in this study was that the low nocturnal blood pressure, whether occurring spontaneously or as a result of medication, may lead to worsening of VF defects. The mechanism of abnormal blood flow in NTG. The first is the instability of blood flow and oxidative stress, which causes the unstable blood flow and unstable oxygen supply, resulted in recurrent mild reperfusion injury, which might cause a chronic oxidative stress. And the vasospasm, it creates an environment dysregulation of blood flow, causing perfusion instability, ischemic changes, reperfusion injury, and axonal loss of the ONH. The endothelial dysfunction, the hyperlipidemia or atherosclerosis and hyperglycemia, impaired endothelial, so no signaling through oxidative stress damage. This leads to increase in AT1, which exerted its vasoconstrictor effect mainly on the microvessels in the retina, which could reduce the blood supply to the optic nerve. The systemic association are migraine, the systemic low blood pressure, Raynaud's phenomena, the Alzheimer's disease, the primary vascular dysregulation PVD, or the Flemmer syndrome. This was a study which shows visual field changes in NTG over 5 years of follow-up. So 62 glaucomatous eyes of 36 patients, and 62% has had progressed over 5 years. Dense paracentral and nasal peripheral, that is 76%, and the dense paracentral nasal or the peripheral and the generalized hemifield loss in the 43.3%. Dense paracentral nasal or the peripheral in both superior and inferior hemifields, which was 26.6%. The isolated nasal or the peripheral scotoma, it was 11.3%, and the isolated arcuate scotoma, it was 12.7%. The normal tension glaucoma, the diagnostic features and comparison with primary open angle glaucoma. Some evidence suggests that NTG with relatively high pressures, greater than 15 mmHg, is more likely to progress than NTG with relatively low pressures. So clinician must be particularly alert to the possibility of NTG because IOP, a clinical marker for some glaucoma, is absent. The ability of peripapillary atrophy parameters to differentiate normal tension glaucoma from this glaucoma-like disc. So the area of zone beta, atrophy to disc area ratio, and angular and extent of zone beta were significantly larger in NTG, and the multiple logistic regression analysis showed that the rim area and the corrected radial extent of the zone beta are variables that show significant difference between NTG and the GLD. So the conclusion, the PPA measurement obtained by HRT can be a useful additional tool to differentiate NTG from GLD after first screening by disc photograph in a routine health checkup. The changes in intraocular pressure and
Dr.
ocular
Gaurav, I think the discussions can be taken part by the examiner. So
Yes.
you have presented your case. Anything else you want to say to conclude?
No, sir. This was a discussion, some
Oh,
studies.
yeah. So I request Rama sir and Pandav sir, Sharmila madam, to please go ahead with the discussion. Thank you, Dr. Gaurav. It was a nice
I
case.
can stop the sharing screen.
Yeah, you can stop sharing the screen.
I think what Dr. Gaurav said about NTG is good. I think he has gone through the literature. Can you hear me?
Yes,
Yeah.
sir. Yes. Yes.
But my question is that your case actually doesn't fulfill the kind of the diagnostic criteria for NTG itself. I think to begin with, you said that NTG is like somewhat elderly population, and your patient is 34 years old. So your patient is actually young. So that's not a age for NTG, I think, as per your own description. So I think there's a issue there. The other thing is by definition, glaucoma would be optic neuropathy, but you haven't actually demonstrated in your case that there is a neuropathy. The only thing you has mentioned is that the CD ratio is 0.5 and 0.6, right eye, left eye. So there is a difference of 0.1. So there is some asymmetry. Unfortunately, we don't have this picture to view, but going by your description, there's a bit asymmetry, but that doesn't actually qualify to call it glaucoma, right? And we haven't got any information about the neuroretinal rim. So when you're describing the disc, you should say about the CD ratio, but more importantly, you have to tell us what happens to the neuroretinal rim. Is it normal? It is, or there is any abnormality? And to define the neuroretinal rim, that means you have to look at the scleral canal, the edges, the inner edge of the scleral canal that you have to identify. You have to identify the inner edge of the neural rim tissue, and then you will make an assessment whether this is normal or this is less, more, or is there any focal defects. So I think those things should come into the description of the optic nerve when you are describing optic disc for glaucoma. And then you have to say something about the peripapillary in the area, the nerve fiber layer. All right. So to say that you have glaucoma, you have to convince us that there is a neural tissue loss there, right? So that means there's a neuropathy there. So I think your description doesn't say that there's a neuropathy, right? Your pressures are normal, and you said the visual field is normal again. So if you want to say you have glaucoma by definition, then you should have something to suggest that there's a neuropathy, there's a loss of neurons, or something has to be there. So that way, I think first you have to convince us that you are actually dealing with a NTG. So what will your diagnosis? What will you label this patient as? I'm not sure I can label this patient as NTG in the first place. So I don't know what RK and Sharmila would say about that.
Sir?
Yeah, Dr. Sharmila, how are you?
Yeah, fine, sir. How are you, sir?
I think, I mean, if we go
Yeah, I
by,
have one or two questions to Gaurav.
Sure.
Yeah.
Yes,
Yeah.
ma'am.
Please go ahead.
So you said you had measured the blood pressure. You mentioned about the blood pressure, which is very, very important in the case of NTG, but you have just given one reading and you're supposed to tell us the time and how you measured in the sitting position or the lying down position. That is very, very important in the case of NTG. So always tell the time. And regarding the diurnal variation, you were telling some measurements of intraocular pressure
Yes, ma'am.
with the diurnal variation. So when and how did you measure this?
Ma'am, we measured with a gap of 4 hours. So we admitted the patient in our ward and we measured this pressure at the 8, then 12, ma'am, at the 4, and then at the evening 4 at the 4 o'clock, then ma'am at the night time then at the ma'am 12 a.m. So ma'am, we at the gap of 4 hourly, we did the ma'am DVT.
Okay, so when was the maximum?
Yes, ma'am. Pardon.
When was the maximum intraocular pressure recorded?
Ma'am, it was in the morning time, ma'am. Ma'am, sorry, ma'am. It was in the night time, at the 8 p.m., ma'am.
8 p.m.
Ma'am, ma'am, 1 minute. Ma'am, ma'am, it was in the 8 a.m. morning that the pressure was the maximum.
So you already measured the blood pressure also. Whenever you're measuring the intraocular pressure for diurnal pressure variation, you should also measure the blood pressure at the same time. Okay, so usually there's a
Pardon,
dip
ma'am.
in the
Actually, ma'am,
nocturnal BP.
sound is echoing, ma'am. Pardon.
Yeah, is it audible now?
Yes, ma'am. Yes, ma'am. No, it's audible.
Yeah. So you should always measure the blood pressure whenever you're measuring the intraocular pressure for diurnal variation.
Yes, ma'am.
Yeah. And that leads to the nerve damage. Yeah.
Yes, ma'am.
And you should have given us the fundus picture and the perimetry picture. Have you taken a perimetry for this patient?
Yes, ma'am. Perimetry was done, ma'am. But ma'am, due to some reasons, ma'am,
Yeah.
it was, ma'am, I couldn't present, ma'am. It was unavailable.
So as already sir has
Presentation.
pointed out, if you have given the fundus picture
Yes, ma'am.
and the perimetry picture, it would have been easy for us to evaluate.
Yes, ma'am.
But you said the visual fields were normal. Is that right? Dr. Gaurav, the perimeter was normal. That's what he was told.
Yes, sir. It was a normal.
This is normal, right? Yeah.
Yes.
Okay. So, but your patient came with headache.
Dr. Ramakrishnan. Sir.
The presenting symptoms were headache, isn't it?
Yes, sir.
So NTG patients, do they present with headache? They do not present with headache, right? So I think maybe he has something different. So what was the cause for the headache in this patient? Because that seems to be the predominant symptom here. And in the absence of any convincing eye finding to suggest that there's an NTG, so I think we should consider that aspect as well.
Yes.
I think Dr. Sharmila said, I think we should have had a look at the optic nerve actually from this picture. That would have given us a little better idea what we are, dealing with.
Yes, sir.
But if I have to label this patient, given the description that you have given, at best I could call it a, glaucoma suspect, because there's some discrepancy in the two eyes because they are not symmetrical. So there is some change. I think you have noticed there is some change in the optic nerve head in the two eyes. I
Yes.
think, and one eye has a larger CD ratio. So probably you are basing your diagnosis on that finding alone. But I think we need a little more information to say that this is NTG. all we have is some change in the disc and the diurnal variation IOP, which is always within normal range in your
Yes.
case.
Yes.
So that's okay. So most people would have a diurnal variation within normal range if they don't have glaucoma.
Yes.
What are the typical optic nerve head changes in normal tension glaucoma? How does it differ from QAG?
This one. Pardon me? Pardon?
What are the specific optic nerve head changes in normal tension glaucoma, which are different from an open angle glaucoma?
This one, ma'am, there is one disc hemorrhage, ma'am. There will be, ma'am, notching, and ma'am, disc hemorrhage notching.
Which specific area of the disc is
Ma'am,
affected in NTG?
yes, ma'am. Like this, ma'am. In our case, ma'am, there was one notching in the inferior part, and the disc hemorrhage was also there, along with
Inferior
the
and inferotemporal.
Yes, ma'am. Inferior part, ma'am.
Inferior and inferotemporal regions are affected in
Yes, ma'am.
NTG.
Yes,
And
ma'am.
there will be the splinter hemorrhage. Can you
Yes, ma'am.
describe the splinter hemorrhages or trans hemorrhages?
The splinter hemorrhage will be in the nerve fiber layer.
Are they significant? How are they significant?
The splinter hemorrhage will be, ma'am, in the nerve fiber layer along with axon of ganglion cell axon.
So if you see a splinter hemorrhage,
Yes, ma'am.
what do you infer from that?
I think you did show a picture, I think I don't think that was your patient, but he did show a picture of disc hemorrhage. So that was in the inferior temporal quadrant. There was splinter shaped hemorrhage, bright,
Yes.
very well defined, superficial, and crossing the disc margin. That's the usual
Got it.
location. Though it doesn't have to cross the margin, but most of them would be related to the disc margin. So that's a very typical
So-
appearance. What you have shown in the picture is a very typical appearance. You just have to describe that. Right.
So, Dr. Gaurav, what made you to think this is a case of glaucoma? What made you to think? Just a large cup or headache or what else?
Yes, sir. To the sir, large cup and sir.
No, when large cup means
Sir, as the
not
patient,
large
he
cup or
with,
glaucoma. No, when you present a case of glaucoma,
yes, sir.
the main hero is the
Sir,
optic
large
nerve.
cupping and the inferior notch.
No, wait a minute.
Yes, sir.
So when you just to tell the optic nerve head finding,
Yes,
you have to do it in a systematic way. Just saying cup 0.5, 0.6, you cannot say it's a glaucoma. You have
Yes.
to tell about the size of the disc and shape of the disc, whether it's a circular, or round, or whether it's a normal disc, or micro disc, or macro disc. All these things matter. Suppose the disc is little larger, then the cup also will be larger.
Yes, sir.
Okay.
Yes,
And
sir.
you have to mention about the nature of cupping, where there is what's the size of the cup and how much deep, it's a shallow cup, or any oscillation, anything is there. Important thing is neuroretinal rim. You should not think and tell the answer. There should be, and also definitely you should have a photograph, fundus photograph. Generally, we can ask questions. Just for merely for headache, 14, 15 tension and just a large cup, you are telling normal tension glaucoma in a 34-year-old male. It's not, it's informed like this. It's not at all good. There is no evidence of glaucoma as pointed out by Dr. Sarmila and Pandav. What is a cup? Just with the cup alone, you cannot diagnose glaucoma. You understand?
Yes, sir.
What's the shape of the disc, size and shape? Is a normal or large disc? No, 0.8 to 10% of the normal population, they will have a large disc.
Large and large cups.
So invariably, they will have being large cup. So you
Yes.
cannot diagnose it with glaucoma. And I have never seen a case of normal tension glaucoma in a 34-year-old kid. And
Yes.
that too is normal tension glaucoma is a disease of exclusion. You
Yes.
have to ask so many negative questions.
Yes, sir.
Hmm?
Sir, yes, sir. So in our
It's a
case, there was a small disc, but sir, the cup was large.
What else? Then in your history also, you have missed so many things. So many, there's nothing about the
Sir, on the recipe also, sir, the
systemic
iron cell
diseases.
was in the lower part of the green graph in the lower side.
What other systemic diseases will you ask for in
Yeah,
your history? As
yes,
sir has
yeah.
pointed out, what all do you ask?
Yes, sir. Ma'am, we will ask for ma'am BP, any hypercoagulable blood, hypercoagulable conditions, or ma'am, like ma'am, this Flamer syndrome, any Raynaud's phenomena.
Yeah, patient had a rheumatic heart disease, right? Could that be related to,
Yes, sir.
how can that be related?
Yes, sir.
Is there
And
any
also you explained everything about the normal tension glaucoma, the theoretical part, how the appearance of the optic nerve head and what are the visual fields. Nothing is here in your case. Nothing, not even a single point to say it's a case of normal tension glaucoma. What Pandav said, what you say? Hmm?
Yes, sir, we agree with you, sir.
Yeah, nothing is there. No? It's something's a headache and just a large cup doesn't mean that patient is having glaucoma.
Yeah, I think we need a better description of the optic nerve head, what was there.
Yeah.
So, and of course, they have done visual fields, which is normal, so that won't tell us anything. And we could have some nerve fiber thickness maps if possible, OCT, but I think clinically also doesn't fit. The profile
Yes.
doesn't fit into an NTG because 34 years old is very unlikely to have an NTG. And it has to be something different. If there's a disc change here, so assuming that there was a disc finding in, asymmetry or some findings were in the optic nerve head, suggestive of glaucoma, then at 34 years age and given your headaches, right? So I would think in terms of neurological also, rather than glaucoma, I think the differential would be neurological. So the question here is that if you have suspected NTG patients, when will you investigate them for neurology? So that would be another question that can be here. So Dr. Gaurav, when would you, if you have an NTG patient or a patient which looks like NTG,
NTG. Yes.
what will the indicators that the person may actually have a neurological problem rather than glaucoma? So what would be the kind of some indicators for that? Any idea? One indicator is there in your patient. We don't know how the disc is, whether it's the cupped or pale, or if there's just a pallor or it's a cup. So if there's a disc pallor,
Yes.
with kind of rim pallor, that would suggest.
Non-glaucoma.
Other thing in your patient is a headache, because
Yes.
the NTG doesn't have symptoms, but if you have a headache, then you're thinking more in terms of
Yes.
neurological.
Yes.
Neurological
Other
problem.
thing is visual acuity. Your visual acuity is
That
6
too, in such cases, Dr. Gaurav, when your patient struggling headache, you should have asked a detailed history about the headache, the nature of headache and the site of the headache and what are the aggravating factors, what are the relieving factors. So many things are there now. This headache is a general symptom only.
Yes.
Any associated with any visual disturbance, any transient obscuration of vision, all these things you have to ask.
Yes.
It can be mere sinusitis or a tension headache. You need not do so much now. So when you subject the patient for neurological examination, as Dr. Apollo asked
Yes.
the question, no? Yeah.
Yes, sir. Sir, as in, okay, so there may be, sir, non-glaucomatous visual field loss, and sir, rheumatic heart disease, also the migraine.
No. When you look at the
No,
fundus
he's
or
asking about
something,
neurological symptoms.
when you subject them to neurological examination and imaging, yeah. MCT, MRI, something like that. When you lost,
Yes, sir. Sir, when the sir, NRR is pale.
yes, yeah,
Yes.
correct. Yeah, the paler exceeds the cup,
Pale.
no?
Yes.
Yes. Mm.
Anything else? Yeah.
Yes.
The other thing is the visual acuity. You have a 6/6 visual acuity, right? Glaucoma patient, they tend to maintain the central vision.
Brilliant,
But
yeah.
the neurological, then the possibility that the central vision might be affected earlier, right? So if the visual acuity is low, again, that would be an indicator. Pale dysphagia already mentioned. Then if you have visual field defect, which is atypical for glaucoma. So, and of course, if you have signs like you have headache or some other neurological signs.
Yes.
So these are the 4 or 5 things which are, if they are there, you
Yes.
should be considering in neurological disorder. You should investigate for that, right? So this patient doesn't seem to be an NTG. I think you have to look a little
No,
carefully.
no glaucoma at all.
No.
Yeah, not glaucoma at all. Yeah.
Yeah,
Absolutely.
yeah. Yeah.
So, but your description of NTG was good, but your patient doesn't fit.
Yeah. That's good. Yeah.
Okay,
You
sir.
have-
Okay. Thank you. Thank you, Gaurav. Read
Thank
well.
you. Thank you, sir. Oja, sir, any last comment
Thank
you
you.
want to make, or shall we go ahead with the next presentation, sir?
Sir, sorry, sir, because of the strike going on in Kolkata, he was
That's all right.
testing for the senior post. So he
Uh,
could not prepare well. This photo, visual field, everything was given to him. But last minute, he is not able to present. Sorry for that. But
that's all right. We are just
patient has the
discussing.
signs. Patient had inferior notch, classical peripapillary atrophy. Everything was there and patient got better after 1 month of treatment. So he could not elaborate properly. But patient has signs we have is treated and patient got better also with the treatment.
Great, great.
Yeah, no, this it's all right. This is just basically for discussion. Just
Yeah.
bring
Yeah.
out certain points.
Yes,
Which
happens sometimes.
the exam is going to ask you in the exam,
Yeah.
your final
Yeah.
exam also.
Yes.
Yeah.
Thank you, sir.
Okay.
Thank you.
Thank you, Dr. Gaurav. Thank you, Oja, sir.
Thank you,
Thank you, sir.
Gaurav.
Thank you.
Despite
Thank
all
you.
the adversities, I think he
Yeah.
was able to present it. And thank you, Oja, sir, for your presence here. So we'll go on with the next case in another half an hour. So 10 minutes for case presentation, Shivam. So Shivam is ready. And the mentor, Dr. UP Dipankar, sir, is also here. Yes. So over to Dr. Shivam Pandey, the third-year junior resident from Netaji Subhash Chandra Bose Medical College from Jabalpur. I'll be presenting a case on ophthalmos. Over to Dr. Shivam, please.
Yes, sir. Just a second. Good evening, sir. I am Dr. Shivam Pandey, third-year resident from Netaji Subhash Chandra Medical College, Jabalpur. I am going to present my case presentation under the guidance of Dr. UP Dipankar, sir, Professor and HOD in Department of Ophthalmology. Sir, my patient Mahesh Chaudhary, 12 years male.
No, you have
resident
to
of
share your screen, Shivam. You have not shared your screen.
Yes, sir. Share. Sir, I have opened.
You keep no. You do one thing. You keep your presentation open. Okay.
Yes, sir.
And then
Yes.
then press the share screen and then open
After
your
that.
listing.
Okay, sir.
So after doing the share screen, don't try to open your presentation. Keep it
Yes,
open.
sir. I have opened it already, sir.
Yeah.
How to stop
Now
that?
stop the screen share and again share screen.
Sir, I am not able to see share screen.
Yeah. No, wait.
Yes, sir.
It's
Yes,
coming.
sir.
It's coming.
Yes,
It's coming. Yeah.
now it's okay.
Yes.
Yes.
Good. Dipankar,
Good.
sorry, Shivam, you can go ahead.
Yes.
You are able to see
Good
us.
evening, sir. I am Dr. Shivam Pandey, third year resident in NSCB Medical College, Jabalpur. I am going to present my case presentation under the guidance of Dr. UP Dipankar, sir, Professor and HOD in Department of Ophthalmology. Sir, my patient Mahesh Chaudhary, 12 years male, resident of Sihora, MP, student by occupation, came to NSCB Medical College, Jabalpur, with chief complaints of large eyes since birth, diminution of vision in both eyes since 5 years. As narrated my patient father, my patient's parents and relatives experience that patient has large eyes in both the eyes since birth as compared to other children of same age and was gradually progressive in nature. My patient also experienced diminution of vision in both the eyes since 5 years, which was gradual in onset and progressive in nature. Then my patient went to a private hospital where he was given topical treatment and was advised for surgical management. And after that, patient came to ophthalmology department in NSCB Medical College, Jabalpur for further investigation and management. In treatment history, he is using eye drop, travoprost plus timolol. He has no history of birth trauma and there is no history of any metabolic disorders. In personal history, his diet is mixed, appetite is normal, bladder, bowel normal, sleep normal. There is no addiction history, no family history, and no allergic history. In general examination, patient is conscious, cooperative, oriented to time, place, and person. He is average build, well nourished, afebrile. 80 per minute is the pulse. Respiratory rate is 18 per minute. BP is 120 by 80, and no pallor, icterus, clubbing, edema, cyanosis, or any lymphadenopathy was present. Cardiovascular respiratory system were within normal limits, and patient is alert, conscious, and well oriented to time, place, and person. In ocular examination, sir, in both the eyes, vision unaided was 660. With pinhole, it was improved to 636. And his BCVA was 636 with minus 5.5 spherical lenses in both the eyes. Position of head was normal in both the eyes. Face and eyebrow was within normal limit, bilateral symmetrical. Eyelids were within normal limits. In eyeball, his eyeball size is enlarged in both the eyes, which is giving the ophthalmos appearance, ox eye appearance. His position and extraocular movements are normal. Lacrimal apparatus examination was normal in both eyes. Conjunctiva was normal. In cornea, size vertical diameter was 13 mm in both the eyes and horizontal diameter was 14 millimeters. Shape was normal. In transparency, half striae was present in both the corneas. Vascularization was absent, and corneal sensation was normal. Sclera, thinning of sclera was present. Anterior chamber depth was deep. Content clear and transparency was clear. Iris pattern, color and were normal and color was brown. There was mild iridodonesis present, sir, in my case. Pupil side shape was within normal limits and reaction was present, reacting to direct and consensual light reflex. Lens was clear and tension by Goldman explanation tonometer was 38 mmHg and 34 mmHg. These are my patient photograph. In right side, his childhood photograph is seen, sir, in which clearly we can see there is enlarged eyes. And in left, we have current photograph of my patient. Sir, in fundus examination, media are hazy due to corneal opacities. In sir, optic disc, in right eye, normal side shape and color was there with 0.9 cup disc ratio with distinct margins. There was thinning of neuroretinal rim with nasalization of blood vessels. In left eye, normal side shape of disc was there with 0.7 cup disc ratio with distinct margins and thinning of neuroretinal rim with nasalization of blood vessels. Retinal blood vessels were normal 0.3 AV ratio in both, and retinal background has peripheral tessellations in both. Foveal reflex was present. So this is the fundus image, which is showing 0.9 CDR in right eye and 0.7 CDR in left eye with peripheral tessellation, sir, and nasalization of blood vessels in optic disc. Sir, on gonioscopy, there was tubular dysgenesis seen. Angles were open, sir. Sir, this is OCT RNFL, which is also showing increased cup disc ratio of patient. Sir, this is ASOCT, which shows increased angles. Sir, this is ASOCT cornea, in which I measured corneal thickness of the patient, which was reduced. Sir, it was in right eye 496 micrometers. In left eye, it was 515 micrometers. Sir, axial length of right eye was 27.88 and in left eye it was 27.52 mm, which is increased. And keratometry, sir, right eye has K1 of 45.87, K2 of 48.53. In left eye, sir, K1 42.87 and K2 45.42. Sir, I have also done perimetry of this patient in which there was generalized reduction of sensitivity was there. And sir, my probable diagnosis of this case is both high primary congenital glaucoma. My differential diagnosis of these cases are high myopia, secondary childhood glaucoma, juvenile open angle glaucoma, megalocornea, healed keratitis, metabolic disorders like mucopolysaccharidosis and mucolipidosis. So further treatment advice for this patient is he should continue medical therapy till patient is not going for surgery, as surgery is the treatment of choice. Sir, in surgery, we can do goniotomy, trabeculotomy, trabeculectomy, combined trab plus trab, glaucoma drainage implants, and monitoring of IOP in long term. Thank you, sir.
I think, thank you, Shubham. I think that was a quite exhaustive description of your patient. Both systemic evaluation as well as local. So how old is your patient now?
Sir, my patient is 12 years old, sir.
Now it's 12 years. So he was detected to have glaucoma at 12 years.
Sir, he was complaining of large eyes, sir. He noticed a little late. But sir, he's visiting doctors since last 6 months only, sir.
But he was on treatment earlier? No.
Sir, when he presented to us, he was using eye drop since 3 or 4 months, sir, only, sir.
Okay. So before that, he wasn't diagnosed. Huh?
No, sir. Before that, he never visited to any doctor, sir.
Do you think at the age of 12, this patient has taken treatment only for 3 to 4 months? He would have been comfortable all these years if it was the primary congenital glaucoma?
Yes, ma'am. Sorry, ma'am.
No. Your age of patient was 12 years, right?
Yes, ma'am. Yes, ma'am.
What is primary congenital glaucoma by definition?
Ma'am, by definition, he should have this problem since birth, ma'am. Ma'am, he also had photophobia earlier, which he didn't complain when he presented to us, ma'am. He had diminution of vision and photophobia earlier and lacrimation, but he didn't tell this to ma'am since he was using some eye drops. He was a little bit relieved by them. Yes, ma'am. Earlier, he had some symptoms of this, ma'am, congenital glaucoma, that is blepharospasm, lacrimation, and photophobia, ma'am. But when he presented to us, then he didn't have those symptoms, and he was complaining of mainly large eyes and diminution of vision, ma'am.
Usually it presents at an younger age, not at 12 years of age.
Yes, ma'am. Ma'am, by definition, he should be of lesser age, but he didn't come to us, ma'am, in his young age, ma'am.
So why not juvenile glaucoma?
And his visual acuity wouldn't have improved so much if it is from the childhood. Because visual acuity was okay with -5 or something, no?
Ma'am, yes, ma'am, he was comfortable with -5.5 spherical lenses. Yes, ma'am.
If it was primary congenital glaucoma, visual acuity wouldn't have improved so much.
Yes, ma'am.
How do you, little curious about this -5? How do you explain that? Axial length is 27.
Yes, sir.
Right? And the cornea is steep, right? 45, 48.
Yes, sir. Yes, sir.
So that kinds of a little counterintuitive to me. What happens to the cornea if the axial length is more?
Sir, cornea thinning has occurred, sir, in this patient.
Cornea curvature को क्या होता है?
Sir,
Larger
steep-
corneas,
yes.
larger eyes, they have a steeper cornea or they have flatter cornea?
flatter cornea.
Generally speaking, yeah. Generally speaking, they tend to have flatter cornea, right?
Yeah, it should have flatter cornea. sir.
Because with the steeper corneas, which is a little, can happen, but a little unusual.
Yes.
So why don't you call it juvenile glaucoma? Why you're calling it congenital glaucoma?
Sir, since he usually, sir, juvenile glaucoma patients present after 3 or mainly, sir, 5 years.
So yeah, so he's 12 years old.
Yes, sir, but his, sir, childhood photographs also showing, sir, that he has large corneas, and his patients also complained, sir, that those corneal opacities which are present in his eyes, he has since
So now
a
the
young
corneal
age.
diameter is 14, you said, horizontal, right? And 13 and
Yes, sir. Yes, sir. Vertical 13,
okay,
horizontal
so
14.
till what time you think the corneal diameter can, become large? So that will tell you the timeline for this patient. Till what time? Till
Sir,
what age? Till what age the eye?
Sir, usually 2 years, sir. Since before that,
Yeah,
sir.
so maximum in the first 2 years, but maybe up to 3 years. And
Yes,
beyond that, the enlargement of glow won't happen. It will be more
yes, sir. Yes.
IPI. So that means the pathology, whatever high IOP was there before the 3 years of age. So that
Yes.
is pointed towards that probably he had glaucoma earlier.
Yes, sir.
Only you saw later. You did mention about the half stria in this case.
Yes, sir.
Did he have half stria?
Yes, sir. He have stress, sir, in both the corneas,
In
sir.
both eyes or only one eye?
No, sir, in both the eyes, sir. Should I show the image, sir?
Yeah.
Yes.
Yeah, show the image. Can you describe the half stria?
Ma'am, in congenital glaucoma, they are mostly, ma'am, due to tear in Descemet's membrane, sir, ma'am. They are mostly horizontal or circumcorneal, ma'am. Ma'am, this was the image I could take in the slit lamp of this patient, ma'am. Sir, is my screen visible, sir?
Yeah, it's visible, but I don't think.
What I
I
can
don't
make
think
out
it is
is
very
that in the
clear.
left eye is actually vertical also component there. Okay. Can you point?
Sir,
Where do you get
Can
vertical
you show it
stria?
with the pointer? Can you show with the pointer where it's try?
sir, these were the opacities in right eye, sir. And in left eye, sir, this was like this, and this was this, and this was, sir, like this, sir. And ma'am, in vertical, we can see in
No.
obstetric trauma,
Which
ma'am.
one is half stria? Half stria will appear as opacity or as
No, yes, sir. Half stria typically has a rail track appearance, sir. Yes, sir.
Yeah.
And ma'am, in we can get vertical opacities in obstetric trauma, ma'am. Vertical or oblique, yes, ma'am. And they are mostly present in left eye due to left occipito anterior presentation of the child. Yes.
This eye in the left eye of this
I
side.
don't think your patient has half stria. I can't make out in your picture.
Ma'am, most probably I was not able to take that picture clearly in slit lamp, ma'am. Maybe that's why, ma'am.
But what you are showing, isn't it vertical? Is the left eye vertical, isn't it?
No, sir. Actually, it has 3 opacities in that, sir.
No, not the opacities. I was talking about the stria. I mean, this picture, it's not very clear, but if you say it was horizontal, we believe that. But whatever you are showing looks more vertical to me. Okay.
Yes, sir.
No, up to now patient is 12 years of age, and this enlargement is there since birth or only after birth now?
No, sir. He had enlargement of in both eyes since birth, sir, which I obtained the information via his photograph in his early childhood, sir. In that he also showed
In
large
that
eyes.
case, in that world photograph, you have any corneal opacity or anything else you able to make out?
So that photo was not so clear, sir. So I was not able to see that clearly, sir. But I asked the patient. He told me, sir, that he had large eyes, and a little bit of opacity, whiteness, sir. He was describing his father. So this was the photograph, but I was not able to see opacities in this photo, sir.
Ask the parents whether the child had any opacity at the time of birth or in early childhood.
So
Sir,
what is the usual age for presentation of primary congenital glaucoma, PCG?
Sir, usually they present within a year, sir, within a year of age, sir.
Usually,
3 years of age.
1 year is a very long time frame,
Yes, sir. Sir, usually, sir, if patient parents are, sir, well aware of diseases, sir, they can present, sir, within days or months of birth, sir.
The usual presentation for
Yes.
PCG is around how much? 3 months, right?
Yes.
Maybe 2 to 3 months. 3 months, that's the usual time. Do you know what is the reason for that?
Of
Why
patient
not at birth? They can present at birth also.
Sir, usually, but sir, patients believe that if a patient have a baby has large eyes, they are beautiful, sir. That's why patient earlier not go to the doctor, sir.
No, Dr. Shivam.
Yes, sir.
The child can born with glaucoma also. Okay?
Yes, sir. Yes, sir.
About majority of the childhood, the primary congenital glaucoma child, they born with glaucoma.
Yes, sir.
But nearly about 65 to 70%.
Yes,
And
sir.
the rest, about 20%, they will have glaucoma, develop glaucoma in the first year of age. Rest
Yes.
only up to 3 years of age. Because the sclera will become toughened at the age of 3 years. Beyond that, there is no more enlargement of the cornea. Okay?
Yes, sir.
After that, only the posterior sclera is elastic, so we will have a anterior posterior enlargement of the globe. That's the reason why you have myopia and juvenile open glaucoma. This
Yes.
finding what your statement, everything is not, it's a contradictory, it's confusing.
And how was the angle you did mention about the gonioscopy?
Yes, sir. Sir, there was anterior insertion of iris, sir, on the trabecular meshwork. That's why I was not able to see the posterior structure, but there was trabecular dysgenesis, sir. Isolated trabecular dysgenesis, sir.
No, he said, don't tell theory, he's asking the findings. What finding
sir,
you are seeing? What's
Iris
about
insertion was, yes,
the
sir.
peripheral iris, all these things you would tell.
Sir, iris insertion over trabecular meshwork was seen, sir. Rest of the iris examination was normal, sir. I couldn't appreciate hypoplasia or hyperplasia in the iris, sir. Anterior stroma, sir. Only I could see iris insertion, sir.
Is there any history of consanguinity? You didn't mention anything about consanguinity during your presentation. Any family history of glaucoma?
Sir, he had no history of any family members of having the same condition, sir, or any of the glaucoma, sir.
What is the inheritance of primary congenital glaucoma?
Sir, there is TIGR gene and there is, sir, a myocilin gene through which it can be inherited, sir. Yes, sir.
No, what any specific gene defects?
Yeah.
Sir, I could remember only TIGR and myocilin, sir. Sorry, sir.
That's for the adults. For children, it is different.
Yes, sir.
So what are you going to for this case?
Sir, patient's parents were not really ready for the surgery, sir. I have counseled them too much. So, sir, his IOP was not controlled on.
Choice in this case? What's the treatment of choice in this case? Medical,
sir,
laser, surgery, medical, laser, or surgery?
Sir, what we should do, sir?
Sir,
Sir, since his age has crossed 3 years and cornea is not that clear, so sir, we cannot go for goniotomy, sir. We can go for trabeculotomy filtration surgeries, but there is a high risk of failure, sir. And sir, medical therapy should not be really done, sir. He should be advised for surgery, except since patient is not really going to get it done, sir. So we are putting him on topical drugs, sir, only, sir. But his since
your pressure is still high, no? Your pressure is still
yes, sir.
38, you said. So topical is not working.
Yes, sir. Topical drugs are not, sir.
And you said you could see the angles. You did the gonioscopy, you saw the angles.
Yeah.
Yes.
So that means trabeculotomy, if you want to do, you could do it in Aventurno. But there's also a way of doing trabeculotomy from outside, what is called external trabeculotomy.
Yeah.
So that's not really an issue. The issue is whether you want to do it or you don't want to do it.
Sir, we should go for surgical treatment of this patient, sir.
What surgical treatment? That's the question.
Sir, trabeculotomy, sir.
You do trabeculotomy because typically trabeculotomy is useful for, patient under what age?
Sir, usually we do goniotomy under 3 years of age, and after that 3 years of age, sir, we go for trabeculotomy.
Up to 2 years, but maybe you stretch it a little further. But
Yes.
the results are best up to 2 years of age, but you can
Yes.
do it as well. Yeah. All right.
Yes.
But at 12 years, whether trabeculotomy is going to be effective or not, we don't know.
Yes, sir.
So what is the best treatment then?
Sir, we can go for laser trabeculoplasty, sir. Since
Laser
drainage
trabeculoplasty is not
Why?
an option for angle which has a dysgenesis, and you say it's a anteriorly inserted iris. So where would you do laser? So that will not be a good option. For laser, you need to have an open angle and need to see the trabecular meshwork clearly.
Yes.
So in this child, probably because of the dysgenesis, as you are also saying, the angle probably is not, trabecular meshwork is not, as clearly visible because of the high insertion of the iris or the anterior insertion of the iris. That's what you described.
Yes.
Right. So that may not be an option here. So what does that leave us with?
For drainage.
No, before drainage, you could do
Plans probably.
trabeculectomy. Why not a trabeculectomy?
Good
The
jump.
drainage would come later, isn't it?
Yes.
Just do a simple trabeculectomy. Just 12 years of old, 12-year-old child. So it has gone a little beyond, the goniotomy and trabeculotomy, but trabeculectomy can still be done.
Yes, sir. Or we can also go for trap plus trap, sir.
Mm.
Yes.
Good option.
I don't know, Dr. Sharmila, would you recommend combined or you would do just the trabeculectomy?
I will do both, Pandav, both
Combined trab
trabeculotomy
and
with
trap.
trabeculectomy. Yeah, that will, because
Combined.
tension is high. And he's already on 2 drugs, Tremeton and Timolol. To go for, or we can go for GAT also in this case.
Yeah.
Yes, that's also a good option. We're having very good result. Yes.
If it is a high insertion of the iris, and if you can actually find the Schlemm's canal, if the Schlemm's canal is there, then if you do, GAT or if you do goniectomy, the iris actually tends to fall back and angle kind of opens up.
Yes, yeah.
So even if it is beyond 3 years of age, still it could still could be tried. But I think most people would do combined trab and trap in this situation.
Yes, sir.
The drainage device, you'll keep it, reserve. I mean, if the last, if it fails, if the trabeculectomy fails, only then you'll think in those terms.
Yes, sir. Yes.
Yeah. Hi. Sant.
Hi, sir. Good evening.
Good evening, Prasant.
Sorry, I missed early part. Thank you for that participation, Pandav sir. And
Nice. Okay.
thank you.
Good.
So I think we are through with the questions, sir. Any more questions? Dr. Sharmila, Dr.
Almost done, yeah. But we can.
I think should presented well. I think he discussed it well.
Thank you.
He had worked hard on this patient, it looks like.
Yeah.
Good.
So I think thank you everyone for this. Thank you both the postgraduates, Dr. Gaurav and Shivam, for presenting such wonderful cases. In fact, trust me, if I had to present in ahead of such a big guns in glaucoma, I would have definitely fared badly than you. But you hold on to your nerves, presented well. And I'm really thankful to both the mentors, Dr. Sushil Oza and Dipankar, for preparing your students so well, so that they could face the top guns in glaucoma so well. And of course, My special thanks goes to all the examiners, Dr. Ramakrishnan sir, Dr. Pando sir, and Dr. Sharmila madam for sparing valuable time at this hour for our postgraduates. With this, I think we can call it a day, sir, with your permission.
Good.
Thank you
Okay,
so much.
okay.
Thank
Okay,
you.
thank
Bye.
you.
Thank you.
Thank you,
Thank you,
everyone.
sir.
Bye-bye.
Thank you,
Thank you.
everyone.
Thank you,
Once
sir.
more.
Thank you.